Welcome back, everyone. For this lesson, we're going to elaborate on the advanced patient assessment. This lesson is intended to be a primer for advanced providers, whether a EMT, paramedic, community paramedic, or critical care paramedic, and really delves into the nuances of why we expand our patient assessment capabilities and the thought and reasoning behind how we approach patient assessment as an advanced provider. Firstly, we need to really understand the continuum of healthcare as established in the United States, and then compare and contrast a bit about the patient types that we predominantly see, particularly in pre-hospital EMS. The U.S. healthcare system really is designed to have patients or future patients have interactions with healthcare providers throughout their life and throughout the continuum of care. This includes wellness visits with a primary care physician, primary care visits as needed, access to specialized care, hospitalization and rehabilitation when it's needed, palliative or hospice care, home health, long-term care, and then again, oftentimes end-of-life care. This is the established healthcare system. Unfortunately, a lot of the patients that we see within pre-hospital emergency medicine as EMS providers often lack access to these fundamental core healthcare components, particularly things like wellness and prevention, primary care, and even specialty care. More often than not, and for most of our patients that we see in the pre-hospital world, our patients' first entrance into the healthcare continuum is when they call 911. A lot of times these patients may have not had access to healthcare in years or even decades, and it's not uncommon that the first time that an adult has had an interaction with the healthcare system is when they call 911. And so when we look at how our patients present to us and the background that our patients have, it becomes important to keep those things in mind, especially as an advanced provider. Now, looking at the future of EMS and kind of where we are trending and where we are going, it sees EMS as a more integrated component of the continuum of healthcare. So not just using EMS providers or pre-hospital clinicians to respond to the call when a patient dials 911, but even up to patient care follow-up, post-discharge, working in conjunction with primary care facilities, particularly in places like rural communities. We see pilot programs across the state and country integrating community paramedics with rural health clinics to do follow-ups and at-home visits on these patients. And this is the trend of where we are going. And so understanding a little bit about the patient types that we see within EMS and then where EMS is going, I want it to frame your position on as we go through patient assessment, we look at detailed assessments and secondary assessments under two auspices. First, you are the knowledgeable healthcare provider that responds to this patient and is their introduction into the healthcare system. You will set the tone for the continuum of care, and we'll elaborate more on that here in a moment. And two, as you're learning about patient assessment and as you're embarking on this journey into becoming an advanced provider, keep in mind that you're not just learning for what we have done in EMS or even what we're doing today. You're also establishing the knowledge base and preparing for what EMS will be tomorrow and for years to come throughout the duration of your career in this profession. Let's talk a little bit about the dual process theory and what we understand as how we think and do things, particularly as relevant to EMS providers. This is a highly popularized theory. It's used by a lot of EMS educators and a lot of professional providers at the physician level, at the mid-level provider level. And the research goes back decades, and it really is that our brain functions in a dual process theory. We have a fast-thinking brain, system one. This is the intuitive, the automatic pattern recognition, the see and react function. And then we have system two thinking, which is our analytical brain, where it's deliberate, it's slow, and it requires us to think through things or allows us to think through things. In EMS and in a lot of professions, we train really well for the system one process. Things like basic life support at the advanced provider, things like ACLS, things like PALS, PHTLS, or ITLS. These are core focused around identifying an immediate life threat and fixing that problem for that patient. We rehearse them to the point that they become intuitive. Unfortunately, this really is only about 10% of the patients that we see in EMS. The vast majority, by a large margin, are patients that are presenting without life-threatening complaints, but have underlying concomitant factors that impact their overall health. These are the patients that we talked about previously that may have never had access to health care or don't have regular access to health and wellness or primary care. These patients often present with ambiguous complaints, things like malaise or stomach ache, or I just don't feel well, or perhaps they complain of things like chest pain, but they don't present in a way that is acute in nature. We're not necessarily invoking the ACLS cardiac arrest algorithm for a patient who presents with chest pain times 6 days. So we need to be able, particularly as advanced providers, to move from this system 1 see and react process over to the system 2, the analytical, slow, and deliberate thought process. The goal as an advanced provider is to recognize when we need to move between these two processes and being able to shift in and out of each. You've often heard it, and I'm sure you've heard it before, that patients don't read textbooks. And so it may very well be that you have a patient that you can engage in system 2 thinking, but they deteriorate into a state where you have to move back into system 1. Peri-arrest is a good example of this, where a patient achieves ROSC and cardiac arrest and feels fairly stable. So you shift over to that deliberate and slow process, but then they move into a re-arrest state where you have to move back into that intuitive or system 1 thinking. So your goal as you go through this and you develop your skills in assessment and you develop as a provider is to be able to interchange between these two systems. Okay, let's talk about some of the perspectives that advanced level providers have that aren't necessarily prevalent in the other aspects of the continuum of care. As the paramedic or the advanced provider on scene, you get to see the patient when and where they are, when and where they exist, how they live, and you have unprecedented insight into the factors that contribute to the patient's current health status. Once we take a patient into the emergency room, or even when a patient goes into a doctor's office, they're oftentimes stripped of identifying characteristics, social determinants of health, their clothing. They're certainly removed from their environment. And at no point in the continuum of care, with the exception of post-care follow-up or home health care, do healthcare providers get to see this patient when and where they are and when and where the events that occur. This allows you, the paramedic provider, to provide critical insight, particularly into the continuum of care and conveying this information and being able to identify factors that contribute to the patient's overall health condition. One of the biggest things that you'll need to transition as you transition into advanced provider is your job is no longer to fix, your job is not always to fix the underlying problem. Your job is more predominantly to identify the factors and provide information and drive the continuum of care for these patients. Here's a real-world example for you. When we see a patient living in this environment, we start to glean things about this patient's lifestyle. And these are not necessarily good things or bad things, but they are assumptions about how the patient lives. When you arrive at a patient's home and the yard is unkept, or it's cluttered, there's things there, the immediate social response is to say, oh, this patient is unkempt or dirty, but the reality may be that the patient may lack mobility to be able to get out and care for their environment. If we look at the picture on the top left of the screen, you can see what we would call a focused area of existence. Around this chair is this entire patient's life. They live here. They exist here. This tells us that they're probably not super mobile. They're probably not able to get up and move about and exercise. That may lead us to assume that the patient doesn't have access to regular health care or wellness. When we look at the bottom left of the screen, We can see an image of a highly cluttered kitchen with no access anywhere to cooking surfaces or cleaning surfaces. This indicates that the patient probably doesn't have a great diet. All of these components together combine to form the situation that the patient exists in and can drive problems that lead to the patient's overall health status. A lot of times when we talk about these things, we're talking about social determinants of health. And so at the very surface, when you, the provider, arrives on scene, we taught you very early in your career to identify things like the chief complaint in your primary survey. And those things are absolutely relevant. And they're relevant for identifying those System 1 patients versus those System 2 patients. But when the patient isn't a System 1 patient, they are that stable patient, we need to think about going deeper into the history for the patient and looking at the things that are driving the patient's lifestyles to put them in the situation that they are in. When we look at social determinants of health, we're looking at things like housing and their environment. Do they have access to food? Do they have food security and nutrition? Their economic stability and healthcare access, and their social and community context. Each of these things can contribute to the overall patient's condition and presentation, and furthermore, it can contribute to their ability to recover post-discharge or post-event. The ability to break the cycle for these patients is to identifying these underlying determinants for their healthcare state and being able to inject interventions and community services to help break that cycle, educate the patients on health and wellness, help them gain medical or medicine literacy, help them identify housing needs and food security and nutrition needs, and helping these patients move into a state where those social determinants of health don't keep causing them to perpetuate the cycle and the overuse of emergency rooms or the use in general as emergency medicine as primary care. That system is not designed to follow a patient through their life and make adjustments to medication routes or administrations or medication doses or provide support for things like housing environments or food security. Their job is to stabilize, and that is what that system was designed for. So you, as the pre-hospital provider on that scene, can help identify these issues and pass that information along. Let's talk a little bit about biases and how they impact our thought process. We are all very much aware that we all have various biases that can impact how we think about patients. And so as we're gathering information, we need to make sure that we're aware of our implicit bias and we help ourselves by recognizing those biases to make sure that we're gathering a neutral decision and opinion of this patient as we start to build information and diagnose that. On the screen here in front of you, there are 5 biases and their descriptions. I won't go through each of them individually. But you can see that particularly in EMS, a lot of our bias is derived not from malintent, but rather exposure bias over years or decades of seeing the same patients. Our brain wants to shift back into that System 1 thinking of, yep, we've seen this patient before. The middle-aged male patient who's unresponsive at 2 o'clock in the morning. Our brain moves toward those assumptions, that anchoring bias, because we've seen this patient a dozen times. That doesn't necessarily mean that that's going to be the case. And so we need to make sure as advanced level providers that we are aware of these biases and move ourselves from that System 1 thought over to that System 2 thought to ensure that we're adequately providing the care and assessing the needs for our patients. As an advanced provider, you've got to take in information from everywhere. We're going to talk about patient assessment in subsequent modules and through labs. But as you gather information from the scene, from your scene survey, from your patient interview, getting that history from the patient, as you take in clues from their environment, as you look at their medications, as you ask about their social history, you evaluate the social determinants of health, you have to be able to funnel and sort all of this information. Not all of this information is relevant at every point in time, but what's important for you, the provider is to be able to take that information, sort it into things like pertinent positives and pertinent negatives. And what I mean by pertinent positives and pertinent negatives is there are things that are affirmed on inquisition or assessment that are pertinent to you. For example, if a patient tells you that they have shortness of breath on exacerbation, when they walk about, that is a positive finding. That shortness of breath is a positive finding, and it's pertinent to where they are. If they tell you that they don't have shortness of breath when they're at rest, that's a pertinent negative. They do not have the symptom at this particular point in time. And those pertinent positives and pertinent negatives, coupled with physical exam and the information from the scene, help you develop that differential diagnosis. The differential diagnosis, the field diagnosis, takes the information from the chief complaint, what that patient says, from your history and physical, things like their medication history, their social history, their food security, their environment that they're living in, things that you're gathering and assessing, and the physical assessment. And you use that to create a field diagnosis. Your field diagnosis is your field impression. And this is a lot of times where we stop, unfortunately, as advanced level providers. Your field diagnosis should not be the end of your diagnostic engine. You should compare your field diagnosis with the appropriate differential diagnoses. So, for example, this mind map on the screen, a chief complaint of acute chest pain, right? Or perhaps it's shortness of breath. Looking at their assessment, looking at their history, they've got a history of a previous MI. They take blood thinners. They're on blood pressure control medications. When you assess their exam, when you perform the physical exam, you note that there are some vital sign concerns. Perhaps their heart rate is a little low and their blood pressure is a little low, but there's nothing on the ECG. You may move with the field diagnosis that it's most probably a coronary event, but you need to assess that field diagnosis against your differential diagnoses. What other things could be causing this? Could it not be a coronary event? Perhaps it's a rate control problem. Is it perhaps a nutrition problem? Maybe it's a toxicology problem. So you need to be able to develop your list of differential diagnoses. And this is where your secondary assessment comes in to rule in or rule out those individual components. Your initial field diagnosis is often derived from your history and your quick physical exam, and then you use your secondary assessment to rule those components in or out with a more or less likelihood. So, for example, let's say that the patient had chest pain. We palpate the chest wall, and we identify that there's tenderness on palpation, or we notice on auscultation that there is wet lung sounds in one particular lobe. Those would lead more to an infection type problem or a musculoskeletal type problem as opposed to a coronary type problem. And while you're not necessarily going to fix an underlying problem, such as an infection in the prehospital environment, this may drive where you take your patient to. Perhaps they are best suited at a community hospital or in future state of EMS at a primary care physician clinic, as opposed to taking the patient over a long distance of time to an acute coronary hospital. These pieces, these secondary assessments, are what you use to rule in and rule out your your field diagnosis based on your differential diagnoses. The other thing to keep in mind as you move through the rest of the assessment modules is that your job at the paramedic level is not to fix every single problem. Your job is to gather information and help drive that continuum of care. We mentioned a moment ago about the patient that may need to go to a lesser acute facility for a lesser acute problem, as opposed to taking them over a long distance to a busier STEMI center or acute coronary location. But it's not just as simple as choosing the right destination. It's about the information that you convey to that receiving facility. Having a thorough history and physical and scene assessment will help drive decisions that those physicians make, those mid-level providers make and the nursing staff make on which pathway to place this person or this individual in as they arrive into their facility. If you don't provide relevant information or you dismiss the patient as not being in need of any services, that the likelihood is greater than not that the receiving facility is going to take your word, and that's the acuity level that they're going to provide this patient until they find information that conflicts otherwise. Likewise, subtle changes that you've identified through a detailed secondary assessment or through an at-home or scene survey or social determinants of health, when you plant that seed of information for the receiving facility, they're going to move in inquisition and drive the patient in that direction. Your superpower as an advanced provider is not the ability to fix every problem. It's the ability to drive patient care through the continuum with the assessment and the information derived when and where the patient was at the time of entrance or at the time of complaint. That's your real superpower.